Presenting today. For our final speakers, I'll just introduce Dr. Lindy Turner, and she'll be speaking with Dr. Erica Cameron-Taylor, both palliative care consultants from the Calvary Mater. Thank you.
So, thank you everyone for having us here today. It's lovely hearing some just hearing her perspective, being the person there that's for families and patients, and I've actually been at the receiving end of her care with a family member, and she's amazing. So, with only half an hour to cover palliative care, we decided to just pick a few areas rather than try and cover the whole area. So 3 things in our outline. I'm going to try and dispel some of the myths around what palliative care is, and give you a bit of a definition so that you guys have an awareness of what we can offer, because I think sometimes people think we're one thing and we're actually a whole lot more. I was asked to also talk a little bit about advanced care planning, which is something that maybe some of you have started to think about, but others in the room may not have. And then Erica is kindly going to cover the section on the services that are provided in this very large geographical area that is Hunter, New England. So I've got a couple of questions for you guys first, and all you have to do is hold up your hands. Who here has had some experience of or involvement with palliative care in the past, maybe with another family member or for yourselves? Okay, I would say that's about half the room. So I realise that people may come with ideas based on the experiences that you may or may not have had in the past. But I think it's important to remember that palliative care sees each patient as an individual, and everyone's cancer story is different. Here's another question. Who here perhaps finds the word or the concept of palliative care a little confronting or maybe a bit scary? It's okay, we know that. We have an image problem sometimes. So a few hands went up. And if anyone's feeling brave enough, what comes to mind when you hear the term palliative care?
Help.
What was that?
Help.
Help.
Dying.
So dying, end of life. I heard help.
Quality of life.
Quality of life. That's a good one.
When are they going to change the name?
Yes, that's what I mean about an image problem. Yeah. And I think the word supportive care is often used, and we think of the two really synonymously, that palliative care, supportive care are in many ways the same thing. But yeah, it's an issue, the name. So there are some common myths, and I think the big one is that people equilibrate the term palliative care with end-of-life care and the last few days or hours of life. But here's some that are very common out there. That pain is an inevitable part of dying. Well, I'm here to say that it's not necessarily inevitable. And one of the reasons for referring to palliative care is that we do our very best to manage pain and other distressing symptoms. And most of the time, we may not get it perfect, and we can't necessarily guarantee completely pain-free dying, but we can certainly go a long way to support you and minimise symptoms. Palliative care is only available in the last few days of life, so yes, people equilibrate it with the last few days of life, but palliative care can be involved for months and in some cases years through the trajectory of someone's illness. Palliative care hastens death, so that's a common misconception that we still face today. Palliative care really has no interest in shortening life, or by the same token, we're not necessarily the people to go to for prolonging life. That's where your oncologists and your surgeons and all the other physicians have a role to play. But I'm going to talk about that a little bit more later, because it's not as cut and dried as you think. Palliative care can only be done in hospital, so no, palliative care can be done in many environments, the home, nursing homes, just two of the main ones. Palliative care means my doctor has given up on me. And that's a tough one, because patients come to us and say that they were told there's nothing more that I can do for you. And that's a really hard thing to hear. But things are changing, and I think that palliative care and all those other specialties, and you met so many of them earlier today, the oncologists, the radiation and medical oncologists, the surgeons, all of them, we all work together, and when one person may not have a role, another person may have a role in supporting the patient. But we never give up on you, we just keep trying. We just have different problems that we're trying to address. And palliative care isn't just for people with cancer. I know this is a brain cancer forum, but we actually look after non-cancer patients as well. There are lots of other life-threatening illnesses with significant symptoms. And it's a bit of a coincidence that this is Palliative Care Week, and the title or the theme of the week is actually, palliative care is more than you think. So the WHO definition of palliative care, it's actually a bit of a mouthful, but I'm going to read it out anyway. It's an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial and spiritual. So that really encompasses quite a lot, and palliative care at its core is a person-centred approach, and we're not just looking at you, the person, we're looking at your whole person, your physical, your psychosocial and your spiritual well-being, as well as the people around you. So it's actually quite a lot to think about. So that's actually the WHO definition of palliative care. But then it goes on and lists a few specific things about palliative care, so I'm actually going to mention them as well. So palliative care is doing two things at the same time. We're trying to affirm life, and at the same time we regard dying as a normal process. So that's a bit of a tension, that we see dying as a part of life, but while you're still alive, we want to make that the best quality that it can be. I've said this already, it intends neither to hasten or postpone death. For some reason that one's not coming up. Oh, there it is. So, relief from pain and suffering, pain and other distressing symptoms is number one. So in brain cancer, that everyone's symptoms are going to be different depending, just like Kath said, what part of the brain is being affected by the tumour. People are going to have vastly different symptoms. And so we want to hear what the reality is like for you. What are the things that you're facing personally? So it might be pain, it might be weakness, it might be visual problems, it might be any number of issues to do with where the tumour is itself. You might be struggling with nausea and vomiting, or breathlessness, and yes, the inevitable bowels, as Kath warned. We're interested in your bowels too, because they can actually affect quality of life too. Fatigue might be something that people are struggling with. Sore mouth, thrush, big one for so many people struggling with the side effects of dexamethasone. Seizures, and I know you had a whole talk from Dr. Pepper about seizures. Depression and anxiety. So these are just some of the symptoms that we will ask you about if we meet you, and any or all of them might be relevant for you, but that's part of what palliative care does. We're curious, we want to know what the things are that matter to you and the things that are affecting you. Palliative care integrates the psychological and spiritual aspects of patient care. So we actually will ask you, are you a spiritual person? Is this something that you want to talk about, or is it not even on your agenda? But we'll at least ask you, and we're interested in what you have to say. And we're very grateful to have pastoral care colleagues, social workers, and people like Kath who support patients and families. And really we're about offering a support system to help people live as actively as possible until death. So we're not just one person, we're a whole team of people, and we're all around trying to make you have a support system so that you can get on with living. And so I love coming to work because I'm part of a team of committed people who genuinely care about other people. And we as a team work together to try and address the needs of patients and their families, and that might even be after death as well. We've actually got a very active bereavement team who support bereaved people. And so we're about enhancing quality of life, and actually there's more evidence out there now that by being involved in a patient's cancer journey earlier, and by addressing symptoms and identifying issues and treating them soon, or referring on to people that might be able to help, the palliative care actually improves survival in terms of length of life that people live. So this idea that palliative care shortens life, there's actually some expanding evidence in the literature that we actually help people to live longer and with better quality of life. So this is just a poster that really summarises what I've just said. And really what I wanted to point out was that palliative care can be done anywhere. So it might be at home, it might be in a hospice, it might be in a hospital. It's for patients and families and loved ones, and the focus is on quality of life. And that holistic approach is really at the core of what we do. And so I know this is a bit of a busy slide, but I think if you look at that tiny circle in the middle, or to the right of the slide, I think that's what people have always thought of when they think of palliative care. It's those final days or hours of life where we come in and we put up an infusion and it's all over very quickly and we go there. But I hope from me talking today that I've dispelled some of those myths, because really the sooner that we're involved from the outset and the diagnosis, we might just be introducing ourselves, we might be beginning some discussions about what your goals are, and we might be liaising with your clinicians who are looking after your cancer. All of that can happen at the same time. They're not mutually exclusive things. And then our input might become more so than your other clinicians as time goes on and the cancer treatment options become less. But we're still focused on living and living your best life. And then when things do get too hard, then yes, we also look after you when you're dying. So this is a lovely study where people and patients facing a life-limiting illness and their families were asked what were the most important things that they would want from their clinicians. And the top 5 elements that they identified as important to them were effective communication and shared decision-making. So they want to understand what's being said, they don't want lots of jargon, but equally they need to feel that the person respects their level of intellect and their understanding, and they want to be part of the decision-making. Seems fair, it is your body after all. They want expert care. They want to know that this person is up to date and that they're giving them all the information about the treatments available to them, and that if they're doing hands-on care, that they know what they're doing as well. I think this is just being human. We want to be respected and we want to be treated with compassion. And we want to feel that we can trust and have confidence in our clinicians. And really, any burdens from the malignancy, they can seem overwhelming. So palliative care is all about trying to minimise the burden. We can't take the burden away, but we can certainly try and support you and make that burden less onerous. So I've been asked to talk about advanced care planning, and I've only got 5 minutes to do it, so that should be easy. So what is advanced care planning? It involves thinking about what medical care you would like should you find yourself in a position where you're seriously ill or injured and cannot make or communicate decisions about your care or treatment. So it's not about now, it's about in the future. Part of that includes thinking about what's important to you, your values, your beliefs, your wishes. And so it might include something as simple as just a really open, honest conversation with your family or your carers or someone who you really trust, or perhaps even with your health professionals, any one of your health professionals. So it might be as simple as that. Or it might be developing something more formalised in the form of an advanced care plan. Or it might go that next step to an advanced care directive, and I'll talk about the differences between those shortly. Ideally, it should be happening when you're well and you're able to understand the choices available to you about your healthcare and treatment. So when you're well and you really know, you're very clear on what the things are that matter to you and you can communicate them well, that's the time. But if you're not ready, it's not something, there's no urgency necessarily. It can be done at any time that you have capacity. It's just something to start thinking about. Why is it important? Well, the fact is nobody can predict the future or what might happen to your health. And as Cass was saying, we all know that we are facing mortality, but none of us know when. And the thing with brain cancer is there are immense advances, they're happening quickly. And so there's more treatments. There's trials, there's radiation, there's chemotherapy, there's immunotherapy, there's tablets, there's intravenous. There's all these treatments available to you. And they might prolong your life. But they also, as Kath was saying, they might actually cause you to feel pretty crook. And you might start to think about, well, I would be able to put up with this particular side effect, but by golly, I don't want to be vomiting constantly every day of the week. Or I'd be happy with a certain level of disability, but if I'm at the point where I actually can't talk anymore, or I have to rely on people for everything, please, that's the limit. So these are things that only each person can think about and decide for themselves. The fact is, some people have some pretty firm ideas about what treatments they find acceptable and unacceptable, and it's not up, but none of us would know if it hasn't been communicated to us. Then we've got to guess. And then, if there is a crisis, then your family or your loved one may find it quite difficult to decide what treatment is best for you and which best fits with your values. If you haven't had those talks, then that's then on your family member. So an advanced care directive will help your family and doctors to know what you would want when you're not able to tell them yourself. And we suggest that it's best to write it down. It doesn't have to be in a formal type document, but if it's written, then there's a clear record of it, so that your wishes are very clearly recorded. One conversation without anything being written down, people might forget what was actually said, or they may misinterpret certain things. But research has shown that families of people who have done advanced care planning have less anxiety and stress when asked to make important healthcare decisions for their loved ones. So I've only been learning about the difference between advanced care directive and advanced care plan more recently. An advanced care directive is something, it's actually a legal document. It can only be made by you as an adult with decision-making capacity. And if it is valid, then it must be followed. It is a legally binding document, and no one can override your advanced care directive, not even your legally appointed guardian. An advanced care plan is a variation, so it can be written by you or on your behalf, and it's more of a document of your values and preferences for healthcare and preferred health outcomes. So if you have a look on the advanced care planning section of the New South Wales website, there's some really good literature there, and there's even a section called My Values, where you actually go through and you have a look at the various scenarios and the things that matter to you and what you would or wouldn't find acceptable, and they use the word bearable. So I would find this bearable, unbearable, or unsure, and it's okay to be unsure. But I think it's actually an amazing website because it helps you to really think through what are the things that matter to me. And probably the biggest part of advanced care planning is appointing someone to make decisions on your behalf. So at some point in the future, if you're not able to make decisions for yourself, you will be in a situation where healthcare professionals will be asking your loved ones. If you have appointed an enduring guardian, so a legal enduring guardian to make medical decisions for you, obviously that would be the first port of call, and if that's written down on a document, well that's quite straightforward. In the absence of an appointed guardian, the next usual priority person would be a spouse or a partner who's had a close continuing relationship with you. And if in the absence of a spouse or partner, the next person would be an unpaid carer, emphasis on unpaid. So that person would be providing potentially domestic support or other sorts of support to you on a regular basis, so they actually know a lot about your needs and your preferences. And failing such a person being available, the next person would be a relative or friend. And that might be someone who you're very close to, who's had frequent personal contact with you over many years, but again in an unpaid role. So that's something also that we encourage people to just start thinking about. Who is my person, or are my people that I trust, who understand what kind of a person I am and what my priorities and preferences would be. So that's it for me. Eric has kindly said she would talk about the next topic, which is about the enormous Hunter New England district and how we service it in palliative care.